We rely on our bones for the fundamental support structure of the body, right?
Absolutely. The entire framework.
But without the joints, the articulations, or arthroses as they're called, where two or more bones meet, we'd essentially be statues.
Just completely static. Our entire ability to move, to interact with the world is restricted to these critical junctures.
And that's exactly what we're here to unpack today.
It is. We've got a dense stack of sources that give us a really rigorous tour of the body's articulations.
So what's our mission for this deep dive?
We're going to trace the complete spectrum of movement. We'll go from the completely immovable seams of the skull all the way to the dynamic ball and socket of the hip.
And in doing that, we're looking for an overarching principle.
Exactly. An engineering truth.
Yeah.
A joint cannot be both highly mobile and exceptionally strong. It's a fundamental trade-off.
Okay, so let's unpack this. Where do we even begin? I mean,
Yeah.
how do you categorize the, 300 plus joints in the body? That just sounds like organized chaos.
It does, but it's organized chaos with a very clear structure. Anatomists use two main methods for classification.
Okay.
There's the structural method, which is based on the material holding the joint together. So, fibrous tissue, cartilage.
The histology of it.
Right. But the method that really speaks to function, and the one we'll focus on, is classification based purely on the range of motion.
So functionally, we're talking about 3 distinct degrees of freedom, from like zero motion up to maximum motion.
Precisely. At one end of the spectrum, you have the immovable joints. Those are the synarthroses.
Syn meaning together, arthros meaning joint.
Exactly. The bony edges are so close they often interlock or are very tightly bound. Stability is absolute.
When I think of this, the first thing that comes to mind are the sutures in the skull. The fibrous connective tissue there acts almost like structural welding between the plates.
That's a perfect analogy. And another great example, this one specific to dental anatomy, is the gomphosis.
Which is the joint binding a tooth into its bony socket.
Yeah, using the periodontal ligament, and then you have the end stage, synarthroses, where two separate bones just fuse completely. The joint is gone. Think of the epiphyseal lines in mature long bones.
Okay, so moving slightly up that mobility scale, we hit the amphiarthroses.
The slightly movable joints.
Right. These are designed for, limited movement, but still providing massive stability for areas that bear a lot of weight.
That's it. The bones here are farther apart, separated by either connective tissue or cartilage. A good example is a syndesmosis.
Like the long ligament connecting the distal tibia and fibula?
Yep. And the second type is critical for the axial skeleton, the symphysis. Here, the bones are separated by a thick wedge or pad of fibrous cartilage.
A durable, flexible spacer. The pubic symphysis is one, and of course the articulations between the vertebral bodies.
The most important ones, really. And then we get to the joints that define movement,
The freely movable joints, the diarthroses.
which are always synovial joints. You typically find them at the ends of long bones in the limbs, and they allow for a huge range of motion.
And a synovial joint isn't just a single hinge. It's a self-contained, high-performance mechanical system. Walk us through its essential components.
It really is a complex machine. It relies on 6 core parts. You have the bones, which are covered by super smooth articular cartilages to minimize friction.
Okay.
Those are sealed within a strong joint capsule, which creates a fluid-filled joint cavity.
And that cavity is lined by the synovial membrane,
Right.
which is what produces the fluid itself.
Correct. Then you just add in accessory structures and the necessary sensory nerves and blood vessels.
But the real secret sauce here has to be that synovial fluid.
Oh, absolutely.
We're talking about a tiny amount, right? Sometimes less than 3 milliliters in a massive joint like the knee, but it's doing, 3 absolutely critical jobs?
3, yeah. Job 1 is lubrication. It's slicker than ice. It contains compounds like hyaluronin and lubricin to reduce friction to almost zero.
Incredible. And job 2.
Nourishment. And this is fascinating because articular cartilage doesn't have its own blood supply.
Right.
So the fluid itself feeds the chondrocytes. This happens when you move. The compression and expansion of the cartilage literally pumps the fluid in and out to circulate nutrients.
So hang on, if you don't move a joint, you're literally starving the cartilage.
You are. Movement is life support for the joint structure.
Wow. Okay, and job 3.
Shock absorption. That fluid cushions the high-impact stresses of, say, running or jumping.
Now, beyond the fluid, the joint relies on other custom structures.
It does. We're talking about specialized cushioning, like the menisci or articular discs.
These are the fibrous cartilage pads, very prominent in the knee, that can cushion or guide movement.
Exactly. And, of course, the ligaments. They're the primary internal reinforcement.
And we group them as either intrinsic which are just thickenings of the capsule itself, or extrinsic.
Right, which are separate straps of tissue running outside or even inside the capsule.
Right.
They prevent any excess movement.
And we can't forget the tiny friction fighters, the bursae.
Little synovial balloons. They're small, fluid-filled pockets you find wherever tendons or ligaments might rub against other tissues. They just prevent wear and tear.
Maybe a quick clinical note here. When those articulating surfaces are forced completely out of position, that's a full dislocation or luxation.
Right. And a partial separation is a subluxation. And, when you hear someone is double jointed, it just means their joints are weakly stabilized.
Which makes them highly flexible, but also way more prone to those dislocations.
Exactly.
Okay, that immediately connects structure to function. So we've built the machine, now we need the vocabulary to describe how it actually moves.
Right. And this is where we categorize the wide world of motion. The sources use a great analogy. Imagine a pencil standing upright on a desk.
Okay, the pencil is the bone, the desk is the articular surface.
You've got it. There are three fundamental ways to move it. The first is simple sliding. If the pencil tip moves straight across the surface without changing its vertical orientation, that's linear motion, or gliding.
Got it. And type 2.
Angular motion. So the pencil tip stays put, but the angle between the shaft and the surface changes. This includes flexion.
Decreasing the angle, like bending your arm.
And extension, increasing the angle, like straightening your leg.
Yeah.
And then hyperextension, going beyond that normal limit.
Angular motion also covers moving limbs side to side. So abduction is moving away from the body's central axis.
It's like raising your arm out to the side.
And adduction is moving it back toward the axis. When you combine all of those into one fluid movement, the limb traces a cone. That's circumduction.
Perfect. And the final type is rotation. The pencil just spins on its own long axis.
For our limbs, we describe this as internal or medial rotation turning inward and external or lateral rotation turning outward.
And in the forearm, we have those specialized rotations. Pronation, turning the palm backward, and supination.
Turning the palm forward as if you're holding a bowl of soup.
The classic mnemonic. And then there are a few special, customized movements for certain areas.
For the foot, right. You have eversion, turning the sole outward, and inversion, turning it inward.
And then dorsiflexion, lifting the foot up, and plantar flexion, pointing your toes down.
So with all that vocabulary, we can now classify the joints themselves based on how many planes they can move in.
Precisely. Monaxial joints move in one plane. Think of hinge joints like the elbow. Biaxial joints move in two planes like the wrist.
And finally, triaxial joints. These are the freedom joints, like the ball and socket, that permit movement in all three planes.
Angular motion, circumduction, and rotation. The whole shebang.
Okay, let's apply this framework. Let's start with two complex joints of the axial skeleton. The first one, the temporomandibular joint, or TMJ. Everyone knows this one because it's so prone to clicking and popping.
Yeah, the TMJ is a multiaxial joint. It's complex because its articulating surfaces are covered in fibrous cartilage, not the usual hyaline, and a thick articular disc actually divides the joint cavity into two separate chambers.
So it's basically two joints stacked on top of each other. This complexity lets it work as a hinge for opening and closing, but it also allows for those small gliding movements.
Which are essential for chewing and grinding. But that structural complexity is also its undoing. Because the capsule is loose, it's poorly stabilized and highly prone to dislocation.
Moving down the core, we find the intervertebral articulations. Here, stability is everything.
It's paramount. You have the symphysis joints between the vertebral bodies with the discs, and then the synovial plane joints or facet joints between the articular facets.
And the hero structure here has to be the intervertebral disc.
Without a doubt. You can think of it like a tire. The tough outer part is the annulus fibrosus.
The fibrous ring.
And inside that ring is the softer, gelatinous core, the nucleus pulposus, which is about 75% water. That's the essential gel core that transmits load and acts as the body's ultimate shock absorber.
But it changes with age, which is fascinating.
It does. As we get older, that nucleus pulposus dehydrates. It loses water. This decrease in cushioning and volume is literally why we get shorter with advanced age.
And clinically, that dehydration leads to problems.
Mm-hmm.
A slip disc is actually a distortion of that tough outer ring.
Right. But a herniated disc is much more severe. That's when the soft nucleus breaks through the ring and can compress nerves.
Which, if it hits the sciatic nerve roots, you get that intense pain known as sciatica.
Or just acute lower back pain, lumbago. And the whole column is held together by a series of powerful stabilizing ligaments.
Okay, let's transition now to the appendicular skeleton. where that strength versus mobility trade-off plays out in the most dramatic way possible.
You're talking about the difference between the shoulder and the hip.
Exactly. Let's start with the shoulder complex. The sternoclavicular joint is the only bony connection between the entire upper limb and the axial skeleton.
Right, it's a small but very stable joint. But the real star of the mobility show is the glenohumeral or shoulder joint.
It is the absolute pinnacle of the triaxial ball and socket design. It has the greatest range of motion of any joint in the body.
Which sounds great.
But that freedom is achieved because the socket is incredibly shallow. Stability is severely sacrificed.
The little stability it has comes from a small lip of cartilage called the glenoid labrum, which slightly deepens the socket. But the core insight here is this. The true stability comes from the surrounding muscles and their tendons.
The rotator cuff.
The rotator cuff. They are the dynamic stabilizers, not the bones or ligaments. And because the capsule is weakest on the bottom, shoulder dislocation is the most frequent joint injury there is.
Okay, so now contrast that highly mobile, low stability design with the joint that supports our entire body mass.
The hip joint, also a ball and socket, but structurally it's the exact opposite of the shoulder. It's dense, incredibly strong, and the acetabulum is deep.
And that depth is significantly increased by the acetabular labrum, making it a very snug fit for the head of the femur.
It's further encased by an extremely dense capsule and reinforced by 4 major ligaments. It is engineered like a vault.
And that stability has a very distinct clinical outcome.
It does. Dislocations are rare. What happens far more often is a fracture of the femoral neck. The bone gives way before the joint itself fails, which tells you everything you need to know about the strength of that structure.
Let's move down to the knee joint. It has to handle massive weight while still providing a huge range of motion, up to 160 degrees, but it's structurally complex.
Very complex. Its complexity comes from its internal structures, starting with the menisci. Those are the cartilage pads that cushion, conform to the femur, and increase the contact area to distribute load.
Supporting the outside are the powerful quadriceps tendon and the collateral ligaments on the sides. But the real anchors are on the inside.
That's right. The crucial intracapsular stabilizers are the cruciate ligaments. The anterior cruciate ligament, or ACL, and the posterior, the PCL.
They cross each other like an X.
To physically limit the tibia from sliding forward or backward relative to the femur, they prevent the bones from sliding off each other.
And the knee has that fascinating locking mechanism.
Yeah, when you fully extend your leg, the tibia rotates slightly laterally. This tightens the ACL and essentially jams the menisci, stabilizing the knee so you can stand without constant muscle contraction.
But given all the forces involved, injuries here are incredibly common.
Exceptionally. Meniscal tears and ACL ruptures are just constant in sports.
And to quickly cover the rest of the limb articulations, the elbow is a stable hinge joint. The radioli joints allow the forearm to pronate and supinate.
And the wrist, or radiocarpal joint, is a condylar articulation allowing multidirectional movement, stabilized by a dense network of ligaments.
Finally, the ankle joint, or talocrural joint. It's a hinge joint where the tibiotalar joint bears the weight.
And it relies heavily on those bony projections, the malleoli, and very strong ligaments. Clinically, the most common injury is a sprain, a ligament tear from excessive inversion, or rolling the foot inward.
Okay, now that we've taken this exhaustive tour, let's zoom out. How does aging affect these precise mechanical structures?
Age changes everything. Rheumatism is just a general term for pain and stiffness, but arthritis refers specifically to diseases affecting synovial joints, usually involving damage to the articular cartilage.
And as we said with the intervertebral discs, we lose height and elasticity. Plus, bone mass decreases with age,
Which drastically increases the risk of fracture. Hip fractures are terrifyingly common and dangerous for people over 60, often due to that combination of weakened bone and the force of surrounding muscles.
This entire discussion really hammers home the point that these skeletal and muscular systems can't be viewed in isolation.
Not at all. They are structurally and functionally interdependent. They form the single musculoskeletal system,
And that interdependence exists on 2 levels. One is the obvious physical connection,
where the connective tissues are continuous.
but the deeper connection is physiological.
It is. Muscle contraction itself is fundamentally dependent on having a very precise, narrow range of calcium concentration available. And where is the vast majority of the body's calcium reserves stored?
In the skeleton, the very system providing the framework and the joints we just analyzed.
That's the ultimate loop.
Every articulation we discussed is a functional compromise. perfectly designed to meet the demands of support versus movement in that specific area.
Exactly. Whether a joint is fibrous, cartilaginous, or synovial, its structure dictates its functional range. It demonstrates that universal principle of the strength-mobility trade-off across the entire body.
So what does this all mean? We've just established this vital functional interdependence between our rigid framework, the skeleton and joints, and our active power source, the muscles.
Which raises an important question. Given that long-term muscular vitality and performance are fundamentally reliant on calcium, which is sequestered in the skeleton, a system we know is susceptible to age-related decline like osteoporosis and arthritis, how crucial is proactive joint and bone health for maintaining muscle performance decades down the line?
That's a deep connection.
It suggests that treating the two systems separately might overlook critical underlying physiological connections that are necessary for true longevity.
That's something for you to mull or explore on your own. Thank you for joining us for this deep dive into articulations.